Hi, my name is Rachel Heidt, and I am a recently graduated pediatric resident at UC Davis Health in Sacramento, California. Although I will be a general pediatrician in the Sacramento area starting this summer, I am interested in pediatric emergency medicine and have been fortunate to work with Dr. Nate Kupperman and Dr. Dan Tancredi for my scholarly project during my residency. Today, I will be discussing our research pertaining to the risks of clinically important traumatic brain injury in children with isolated altered mental status after minor blunt head trauma. I have no financial or other disclosures on this topic. Traumatic brain injury, or TBI, annually accounts for more than 812,000 ED visits, 23,000 hospitalizations, and 2,500 deaths in children ages 17 and younger in the U.S. In a report from the CDC in 2018 based on diagnostic coding, 85% of ED visits for TBI were for mild TBI, defined by an initial presenting Glasgow Coma Scale score of 13 to 15. In 2009, an article by PECARN investigators led by Dr. Kupperman was published in The Lancet entitled Identification of Children at Very Low Risk of Clinically Important Brain Injuries After Head Trauma, a prospective cohort study. This study enrolled 42,412 children younger than 18 years old with minor blunt head trauma within 24 hours of injury at 25 emergency departments across the U.S., with the goal of creating a CT decision rule. Excluded were children with trivial injury mechanisms as well as those with penetrating head trauma, known brain tumors, pre-existing neurological conditions, or those that received neuroimaging at an outside hospital prior to transfer. The outcome measure was a clinically important TBI, defined as death from traumatic brain injury, neurosurgery, intubation for more than 24 hours for TBI, or hospital admission for 2 or more nights associated with TBI found on CT scan. There are 2 age-dependent rules that were established from the results of the parent study to help guide clinicians on CT decision-making as demonstrated in the 2 columns on this slide. To walk through these briefly, for children under age 2, if they present initially with a GCS score of less than 15, other signs of altered mental status, or a palpable skull fracture, they are considered at high risk or 4.4% risk of a clinically important TBI, and CT of the head is recommended. If children do not have these signs or symptoms, but present with a non-frontal scalp hematoma, loss of consciousness for greater than 5 seconds, a severe mechanism of injury, or not acting normal per their parent or guardian, they are determined to have intermediate or 0.9% risk of a clinically important TBI, and observation versus CT of the head on basis of other clinical factors is recommended. For children ages 2 through 17, it is the same concept with slightly different risk factors. With a GCS of less than 15, other signs of altered mental status or signs of a basilar skull fracture considered to be high risk for clinically important TBI and CT advised, whereas history of loss of consciousness, vomiting, severe mechanism of injury, or severe headache are intermediate risk for a clinically important TBI, and observation versus CT head recommended. After the initial study was published in 2009, many secondary analyses have been performed focusing on the different PECARN clinical criteria, such as vomiting, loss of consciousness, etc., in an isolated context. But altered mental status, including a GCS of 14 in isolation, has not yet been evaluated in detail. For this study, we sought to determine the risk of a clinically important TBI in children under 18 years old with isolated GCS scores of 14 and/or other minor signs of altered mental status after minor blunt head trauma. We performed a secondary analysis of the PECARN head injury database. We defined altered mental status as a GCS score of 14 and/or other signs that include agitation, somnolence, repetitive questioning, or slow response to verbal communication. We defined isolated altered mental status as a presence of altered mental status but with the absence of all other PECARN age-specific risk factors. We estimated and compared age-specific, clinically important TBI risks in those with and without isolated altered mental status, using exact and score confidence limits respectively. We excluded any children missing PECARN risk factor data. We found that 10% of the children included in the original study population were found to have altered mental status on initial presentation. Out of that group, for those younger than age 2 with isolated altered mental status, about 1% were found to have a clinically important TBI. And in the same age group but with non-isolated altered mental status, that number rose to 3.1%. For ages 2 through 17 with isolated altered mental status, about 1.4% were found to have a clinically important TBI, whereas in the same age group but with non-isolated altered mental status, that number rose to 4.3%. These tables illustrate that the risk of a clinically important TBI increases with each increasing number of PECARN risk factors that a patient presents with beyond the altered mental status variable. In the top table for ages under 2 years old, you can see that the percentage of patients with a clinically important TBI goes from 1.03% for those with isolated altered mental status to 1.14% with the addition of one other PECARN risk factor, and then up to 6.37% when you add on 2+ other risk factors. The bottom table demonstrates a similar trend for children ages 2 through 17, where the risk of a clinically important TBI for those with isolated altered mental status at 1.43%, with the addition of one other PECARN risk factor, 2.25%, and then with 2+ other risk factors, 9.27%. Limitations of this study include that this was a secondary analysis of the PECARN head trauma dataset. However, the data were initially collected prospectively. As we are all aware, the GCS score is inherently somewhat subjective. However, there have been studies that have found that the inter-observer reliability of GCS is excellent. The PECARN head trauma CT rules were derived in academic pediatric centers. However, there have been multiple external validations in both academic and community emergency departments worldwide that have shown that these rules are associated with a safe reduction in CT usage. In conclusion, children with minor blunt head trauma presenting to the emergency department with a GCS score of 14 or other minor signs of altered mental status and no other PECARN risk factors are at more than 1% risk of a clinically important TBI, and strong consideration for CT of the head should be given. The risk of a clinically important TBI increases with each increasing number of PECARN risk factors that a patient has. Given the 1% risk of a clinically important TBI, which is really neither high nor low, there may be room for shared decision-making for delaying CT after a period of observation for 4 to 6 hours in the emergency department versus an immediate head CT in those with isolated altered mental status. However, it is important to note that in most of the previous secondary analyses looking at other PECARN intermediate risk factors in isolation, such as acting abnormally, loss of consciousness, and vomiting, the risk for a clinically important TBI was substantially lower than 1%. The outcome in question for this study is a serious TBI that requires hospitalization at a minimum, not just a positive CT scan, and this is something that none of us would want to miss. Thank you everyone for listening to this virtual presentation and the opportunity to present, and a special thank you to my mentors Dr. Kupperman and Dr. Tancredi for their guidance and support. If you have any questions, please feel free to reach out to me via email. My email is listed on this slide, and once again, thank you for listening.